All right, starting back with pelvis trauma series here, okay? So we're going back to first semester. Remember inlet and outlet pelvis that we talked about, or Taylor method? So just remember, outlet projection is tube angles determined by pelvis shape. So males were 20 to 35 degrees cephalad, or females are 30 to 45 cephalad angle here, centering 1 to 2 inches above symphysis pubis. And we're looking for elongated and magnified pubic and ischial bones here. Just trying to elongate those. And inlet projection, 40 caudal at the level of ASIS. And you're looking for, I always feel like this view, it looks like an alien. But you're looking for ischial spines demonstrated in equal distance here. All right, the posterior obliques for pelvis, we call those the Judet method or Judet views. They're 45-degree obliques, and we're looking at the acetabulum. So we normally do an upside and a downside of the same side. So you can see how she is obliqued LPO, and the right side is up on this one. And then she's turned RPO, and now it's a downside, but they're both of the right side, okay? So central ray, when she's turned up, is 2 inches distal to the upside ASIS. When she's turned down, 2 inches distal and medial to downside ASIS. So RPO and an LPO, we're still sticking for the right for our example. So LPO, you would be using the upside, which is the right. The right side will be up when the patient's LPO. What are we looking at? We're looking at the posterior rim of acetabulum and anterior iliopubic column demonstrated. And then when you do the right side down, so RPO, still looking at the right, you've got the anterior rim of acetabulum and posterior ilioischial column. And you can see how the wing here is larger. It looks flat. This one, they're rolled onto the table. When it's up here and sharp, this is away from the table. You can also see how the femoral head is magnified more than this one because it's further away. Also, your obturator foramen here is much larger and open. This is up and away. This is closed because she's rolled onto that side. All right, axiolateral, inferior, superior, or Danielus-Miller method. Make sure you know all three of those names. We call it cross-table lateral hip or shoot-through hip in the clinical world, but textbook-wise and board-wise, you're going to want to know this information. So axiolateral, inferior, superior, because you're shooting from inferior to superior, right? Danielus-Miller method, central ray perpendicular to mid-femoral neck, right? Axiolateral projection, make sure you go back and review that pelvis anatomy. What it should look like in your ideal world and your perfect patient that's really little, right, would be beautiful like this. The modified axiolateral, also called the Clements-Nakayama method. When do we do this? When would you use this? When both hips are fractured. Know that, circle it, star it, all right? When they have bilateral hip fractures, you're going to use the Clements-Nakayama method. It's basically a modified shoot-through, right? Because you can't lift the other leg up and out of the way if they're both broken. So what are you going to need to do? A lot of angling. So you need to angle your cassette. You need to tilt your cassette, but you also need to match those angles with your tube, and that's the hardest part. Trying to match those angles with your grid cassette. So central ray is 30 to 40 degrees medial lateral and 15 to 20 degrees posterior from horizontal. You're still centering in the same place. So we will do this in Lab on Lenny. It's just easier to demonstrate there. All right, but that's for bilateral fractures. Going back, I want you guys to review, how do you evaluate pelvis for rotation? I want you to look at the shape of the iliac crests. Are they equal, right? Are they symmetrical? This one is obviously not, right? Look at the size of this one compared to the size of this one. Look to the obturator foramen, right? Are they both open or is one closed? This one's clearly open and this one is closed. Obviously, this femoral head is not where it's supposed to be, right? It's not in the right place. There's a lot going on in this patient's pelvis. But crack open that textbook. I want you to review how you evaluate for rotation. Just a quick reminder for dislocation can be anterior or anterior posterior for hips. How are they gonna present? Hip prosthetic, that head can pop out of that cup very easily, unfortunately. But posterior, the patient's usually flexed and internally rotated and adducted. Anterior dislocation, the hip is minimally flexed. I've had a few that are majorly flexed. So this one right here, major flexion, it's way up in the air. Often externally rotated and markedly abducted. Just a quick little cheater there, right, for anterior versus posterior dislocation. It's not going to look right, right? Just a reminder, the pelvis like a pretzel. It's almost impossible to break the pelvis in one location without suffering a break or a fracture in a second location. So this is why it's really important to get more than one view a lot of the times, all right? Open book fracture, remember this one? Separation here, all right? The front of the pelvis looks like an open book, super painful. But this injury is dangerous and the patient's condition can change quickly. Why? Because this a lot of times leads to some severe bleeding. So your patient that has this may be in a binder. Do not remove the binder, all right? Don't do it. Some crush injury. There could be lateral compression. Oh, I went too fast. Getting hit from the side, all right? Cranium. Most of your head trauma patients, they're going to CT, but sometimes x-rays are ordered. So cross-table lateral skull. If your patient's a trauma patient, if they're in a neck collar, obviously you're not going to sit them up or stand them up or put them prone or anything for skull work. So you're going to do a cross-table lateral skull. Same thing, all right? Same central ray. A trauma AP skull, you can use a 0-degree angle, right? Obviously this patient has a knife through their head. They probably can't go through the CT scanner. So you may have to do an EP skull, right? Shooting straight on. AP axial skull. So you guys know the town views, right? So 30 to OML or 37 to IOML. Looking at the dorsum sellae in the foramen magnum here. Trauma Caldwell. Anytime you're reversing the patient, the tube angle direction reverses, right? So toes up, angle up, toes down, angle down. Normally, we do a PA Caldwell, we angle 15 degrees down. My patient is now supine. An AP, I'm going to angle 15 degrees up. You know that, right? A Waters view. AP, we call it reverse Waters. Just a reverse direction. So normally this Waters view is for sinuses, but if for some reason they ask you to do facial bones, you guys probably will never do a trauma head series, but just in case, you just reverse everything. So most of the head stuff goes to CT. And severe spine trauma, they go to CAT scan too. So you're not going to do a ton of this stuff. Just a review for orthopedic devices. So internal fixator devices, you guys have seen these quite a bit. Plates and screws. External fixator, they might abbreviate it and put X-fix on it. Pelvic external fixator. Intramedullary rods, you guys have seen these in the OR. These are what are getting hammered down the patient's legs. And then you're having to do perfect circles for Dr. Brecht in the OR. Hip fractures and pinning. You guys know this stuff, but just a quick review, right? So it could be femoral neck fractures, the subtrochanteric fracture, intertrochanteric fracture, internal fixation. They can use cannulated screws and pins to put that back. C-arms, C-arm alignments, shooting through. watching your angles. Most often AP and lateral. Total hip replacements. We're usually not using a C-arm most often for this. We may do a portable pelvis post-op for these, but there's a lot of different types of prosthetic devices. And just remember, you want the entire prosthetic on your image. For your total hip replacement, make sure you get all the way past the prosthetic here. When you're taking your hip x-rays, if your patient has a prosthetic, include the whole thing, even if you have to use a longer cassette. Right? The nailing, you may need to use some angling. This is just a review for lumbar spines, PA and lateral, or AP and lateral, depending on how the patient is positioned. The laminectomy fusion, they may come post-op. Usually these are the ones you guys do on miscellaneous. A couple months later, they're having just an AP and lateral, looking for their hardware and to see how it's going. All right, and that rounds out trauma. Just review, go back through and read I think it's chapter 15 in your book is our trauma chapter. I think a lot of you did it first semester for me when we went through some mobile x-ray stuff. But do me a favor, go back through and read your chapter 15, review your fractures, fracture types, what they look like, and specifically trauma views, looking at those elbow trauma views. Those are specific trauma views for elbow. So go through those for me because I think a lot of you had already done your workbook for it. So go through your workbook, answers, and the chapter. So chapter 15 will round it out, okay?